Okay, people, I'm here to do your exam number 4, respiratory review. Hold it, there's somebody here.
You realize you're in class recording, right?
Oh, yes, no, I'm just getting the, just a recording.
I saw that pop up and I was like, you're in class. Okay.
No, this is just getting them ready, just review for the test on Monday. So. Okay, that was Jody picking my head in here saying, you realize that all the PN2 students are in farm right now. And I'm going, yes, this is just a review for Friday. So sorry, interruption. And then I didn't hit the record button. Well, I guess I hit the record button, but I didn't confirm to pause the recording. So you heard the entire conversation. All right, let's get going on this. This is for the adult portion of exam number 4 that's going to be held next Monday, which is October the 5th. And there will be 30 questions for the adult side and 30 questions for the pediatric side. So let's get going. So first of all, we started with the health assessment, the health history assessment for the respiratory focused assessment. And so if you remember that I referred you to an acronym that is used sometimes in asking questions about any respiratory issues that the patient has. And the acronym is, it's what's up. So the W stands for where is it? H stands for how does it feel? A stands for aggravating and alleviating factors. T stands for timing, S stands for severity, U stands for the use of other data, and P stands for the patient's perceptions of what he or she feels is going on or happening with their body. You also want to be able to differentiate between painless and fixed enlarged lymph nodes and tender and movable lymph nodes. So be able to describe those things. Also, you want to identify any abnormal findings that you would find in the physical respiratory assessments. So anytime that you have a respiratory rate of less than 12 or greater than 20 breaths per minute, you want to investigate that a little bit further. You want to definitely try and ascertain what the cause is for a person that is using their accessory muscles or using retractions to help facilitate breathing. If the person has a barrel chest, you definitely want to ask them if they've had a history of smoking. Also, you want to be able to describe different adventitious breath sounds and normal breath sounds, which you were able to do both in the baseline and in the comprehensive health assessments. You want to ask them about if they're having any sputum production and if they have noticed any discoloration of the lips whatsoever, if they have any nail clubbing, if there is confusion. So why would I ask something neurological when we're looking at focused assessment of the respiratory system? Well, since nobody's here, I'll answer that myself. It is a definite sign of hypoxia, which is a respiratory issue. You also want to talk to them if they have any unexplained weight loss and have them describe the process of eating for them. So when we're talking about hypoxia, really quickly, just tell me what is about the only way you can reverse hypoxemia or hypoxia is increasing their oxygen availability in their body. All right, so one of the things that you may want to recall from our past discussion on skin, hair, and nails is being able to describe cyanosis, which is a sign of hypoxia, in a dark-skinned person, and be able to describe it in a lighter skinned person. What exactly are you looking for? So cyanosis or decreased hemoglobin levels in darker skin people give the skin more of an ashen color instead of a bluish the bluish color that you see in lighter skin people. So be able to differentiate between the two. You also want to define orthopnea and different breathing patterns. So what is orthopnea? Oh, yeah, nobody's here. Forgot that. I'm so stupid. So anyway, orthopnea is dyspnea that is relieved in an upright position. Okay, dyspnea is relieved in an upright position. Biot's breathing pattern, if you remember that, it's irregular respirations of variable depths, and it alternates with periods of apneas. And a lot of times you'll see this when person is not, they're having a near drowning incident, or maybe they, during CPR, they will be breathing, but it's ineffective ventilation of the body. That's Biot's breathing pattern, and recognize that their respirations can be very deep or they can be very shallow, just whatever the body's doing. Cheyne-Stokes breathing is usually associated when the person is in the active phases of dying. And what happens here is that the respirations gradually get faster and they get deeper than normal, but then they alternate that with periods of being very slow, and then with occasional apnea where, as I said, it can be up to 45 seconds, it can be up to 2 minutes, and then all of a sudden they'll gasp for breath again. So Cheyne-Stokes breathing is associated with the active phases of dying. Kussmaul respirations are always associated with DKA, and that's where it's much faster and much deeper respirations without any pauses, without any apnea at all. And this is just someone that is trying to blow off the acidosis from the blood. Tachypnea, of course, is breathing faster than 20 breaths per minute. So again, we talked about that you need to be able to describe adventitious breath sounds as well as normal breath sounds. And then you also want to be able to identify the signs and symptoms of atelectasis. And we talked about this in the lecture. What is atelectasis? It's the collapse of the alveoli. And what happens when the alveoli collapse or they stick together, then this prevents the respiratory exchange of carbon dioxide and oxygen in any given part of the lung. So what is another sign or symptom of atelectasis? It's going to be diminished breath sounds. And a lot of times they'll have a low-grade fever with it, and they will have an increased shortness of breath. But remember that atelectasis is very commonly seen in post-op patients within the first 24 to 48 hours after they've been under general anesthesia. So this is specific to patients that have been under general anesthesia. So what are some interventions that we can do for atelectasis? First of all, pulmonary toileting. And that is not a term that you will find in the textbooks, but it's definitely something that we call it on the floor when we're at the bedside. And this is where every single hour you go into the patient's room and you have them do incentive spirometry for 10 times. And this is where they take a deep breath, hold it for 2 or 3 seconds, and then exhale. And we do that 10 times every hour. We also turn, cough, and deep breathe them every single hour. And we want to ambulate them as soon as possible after surgery. We want to identify different kinds of pneumonia as well. We talked about atelectasis. We talked about pneumonia. There are different kinds of pneumonia: bacterial pneumonia, viral pneumonia, fungal pneumonia, aspiration pneumonia, hospital-acquired pneumonia. There's all different kinds of pneumonia. Why? Because the only things that belong in the lung is air. And yet we manage to suck things down the trachea all the time and get pathogens in there that begin to grow. And what happens with pneumonia as those pathogens begin to multiply, the toxins are released that induce inflammation in the lung tissue, and it damages the mucus and the alveolar membranes. And so when that's damaged, then that leads to the development of edema and inflammation of the lung tissue, and exudate, which fills up the alveoli and reduces the surface area available for the exchange of carbon dioxide and oxygen, thus having the person not have the surface area enough to meet the metabolic demands of the body, and they end up desatting or not being able to meet those demands, which is also known as respiratory insufficiency. So what are two nursing diagnoses that are associated with pneumonia? First of all, there's ineffective airway clearance and impaired gas exchange. So ineffective airway clearance and impaired gas exchange are two very appropriate nursing diagnoses for pneumonia. And then we also have signs or things that we want to do for for a pneumonia, and it's pretty much the same things that you're going to do for atelectasis, and that is pulmonary toileting. We're going to have them turn, cough, and deep breathe every hour. We're going to have them do their incentive spirometry every hour. We want them up and walking as soon as possible. When I was at the bedside in the PICU unit, when a patient had open heart surgery, they were up walking by that evening. Yeah, the surgeon wanted us up and having open heart surgery, people. We had them sitting up in bed, and then we had them dangling on the side of the bed. And then the next morning we had them actually ambulating. But we had them up and put in a transfer to a chair so that they're sitting up again. Sitting up and standing up is the way that we can allow the full expansion of all the alveoli, which is going to help prevent pneumonia. So remember, that's what we want to do. We want to suction as much as possible. If we need to, get those secretions out, open up those lumens to the bronchial tree. Okay, so we also talked about pulmonary embolism. And so what is a pulmonary embolism? And I don't think I mentioned this yesterday. We talked about the pulmonary embolism being an embolus, or a piece that has broken off from a thrombus, from a blood clot. And we talked about blood clots, and we talked about the risk factors for developing a thrombus. But what you need to be aware of is that pulmonary embolism can also be from a fat embolus. So when you have had some kind of trauma to the body, and there has been some disruption of the adipose tissue, then you have a high likelihood of developing a fat embolus. So an embolism doesn't necessarily have to be just from a blood clot. It can come from a piece of fat that has been traumatized and been disrupted, or it can even be from air. So this is why we try and get all the air out of the syringes and the needles before we inject medication, because that air, again, the bubble can be so large that it occludes an artery, and you end up having a pulmonary embolus. We talked about the different risk factors for the development of a thrombus, so you want to review those. The signs and symptoms of a pulmonary embolus are what? What are they? Do you care? No, you don't. I know, I can tell. But what we want to do is be sure and know what these signs and symptoms are so we'll recognize them, because it can come on very suddenly. It doesn't matter if it's blood, fat, or air. Doesn't matter. It's very sudden when that pulmonary circulation vessel gets occluded. And suddenly the person is going to have this onset of dyspnea. It can even be when the person's at rest. But what happens then is that the person is going to be having chest pain. And the reason for that is that the right ventricle fails to be able to push blood into the occluded pulmonary artery from the heart. So what happens then is that the person has this severe shortness of breath and severe chest pain, and they get very anxious because this is so out of the blue. They're just sitting there watching TV, and all of a sudden they have this horrible chest pain because of the pressure in the heart, and they can't breathe. They've got a shortness of breath. So, what are two diagnoses for a person that is experiencing pulmonary embolism? Ineffective breathing pattern, because they've got shortness of breath. They are sucking air, people. You talk about using retractions. Yeah, they're using all of their accessory muscles to try and inflate the lungs. Also, there's going to be impaired gas exchange, because as there is occlusion of the pulmonary vessel, then what happens then is that there is no blood flow distal to that. And so when there's no blood flow, then there's not going to be any gas exchange. And of course, the person's going to have severe anxiety. So 3 very, very, I know I asked for 2 nursing diagnoses, but these are actually 3 very appropriate nursing diagnoses for pulmonary embolism. So what do we do for somebody that has pulmonary embolism? If it's a blood clot, then we're going to do ATP, which is a thrombolytic medication. It has to be given within the 4 to 6 hours from the onset of symptoms or the occlusion. And this is going to break up that clot and allow the lumen to be open again. However, they will also be started on heparin therapy, because whatever has caused that blood clot can cause another one. So we want to prevent the formation of new clots, and we administer heparin. Usually at the very, very beginning, it's a heparin drip where we're administering medication, but as a person's blood normalizes in its viscosity, then we can go to oral medications such as warfarin or Coumadin. Okay, so let's move on to 3 diseases that, interestingly enough, can all be triggered by smoking. And so when we talk about COPD, we associate it highly with a history of smoking. And it doesn't really matter how long you smoked. You can smoke for 2 years, you can smoke for 30 years. It's all genetics, people. Yes, it's all genetics. But we do know that smoking triggers all these disease processes. And whether or not you develop COPD is really a genetic thing. It's a crapshoot. But for the most part, we do know that people that do develop COPD have all smoked. So it's a definite trigger for development of COPD. But there's 3 disease processes that are associated with COPD, and the first one is chronic bronchitis. So what happens here is that the bronchial tree becomes inflamed from inhaled irritants such as smoke or even secondary smoke. And that smoke will go inside the bronchial tree, and it starts to impair the ciliary function of the cilia that line the trachea down into the bronchial tree. And it reduces the ability of the bronchial tree to remove those irritants or remove any pathogens, because it doesn't move, the cilia doesn't move the mucus up from the distal portions of the tree and the bronchioles up the trachea so that you can cough it out and expel it. So what happens also when the cilia isn't moving, there's the mucus production glands in the airway become hypertrophied, and they start to produce excessive, thick, tenacious mucus, which traps bacteria. And the bronchial walls thicken and the bronchial lumen narrows, and then you have this excessive amount of mucus that's going to plug the airways. So the patient will start to exhibit wheezing because of the narrowed lumens in the airways. And then, of course, this sign or symptom that most people are going to begin noticing is that they have this chronic, productive cough. And sometimes we refer to it as the smoker's cough. Another disease process that is one of the three classic signs or diseases that has caused COPD is asthma. And the asthma is basically defined as a chronic inflammatory disorder of the airways. And it is intermittent, so it can be reversed in not the disease process or not the hypersensitivity of the bronchial tree, but you can reverse the airflow by opening up the airways with bronchodilators and specific medications. So we just know that the airflow in the bronchioles themselves becomes very obstructed. And again, you have this classic sign of wheezing. So with the asthma, you get mucosal edema, and then your bronchioles are constricted because of this inflammation of this edema that is narrowing the lumens. And then you have excessive mucus secretion again. And so what is maybe a primary goal for persons that has chronic bronchitis or asthma? It's going to clear the exudate. Yep, it's the exudate, it's the inflammation of the airways, but you gotta get the exudate out of the airways so that you can have and maintain adequate oxygenation because of the improved gas exchange. So we got to get rid of those secretions to make it work. Then the last disease process that is associated with chronic obstructive pulmonary disease is emphysema, which has been defined as the loss of elastic recoil as a result of smoking. And because of this loss of elastic recoil of the alveoli, then passive exhalation of air in the lungs is impaired, and then air becomes trapped in the alveoli. And so the combination of damaged alveoli and capillaries causes a reduced surface area for gas exchange. So you're going to start desatting. And then the impaired oxygen diffusion causes this hypoxemia, which causes the desatting. And then you have a person that has respiratory insufficiency or the inability of the respiratory system to meet the metabolic demands of the body. So the loss, one thing I didn't mention yesterday that I really wanted to mention today was that there is a loss of surface area and a loss of capillaries that are feeding those alveoli. And what is going to happen is that this results is not only in a loss of surface area, but it also results in resistance as well. So now you have a reduction in the number of alveoli, And you're also going to lose the available capillaries that are needed for the blood to flow into the venous vasculature from the heart, and after it goes through the lungs and becomes deoxygen or reoxygenated. But now we don't have that available because of the loss of surface area. It's going to result in backup pressure to the heart, which over time is going to cause right-sided heart failure because of the right ventricle having to try and push this blood over into a pulmonary system that just doesn't have enough vessels to handle it, and you end up with cor pulmonale. So don't forget that, don't forget that that is a result. Cor pulmonale is right-sided heart failure, but when it's related to respiratory system or respiratory failure, then it is called cor pulmonale. Okay, so the first thing that somebody with COPD notices is the morning smoker's cough, which we've already talked about. And so the characteristic symptoms, or the classic symptoms, whatever you want to call it, of emphysema include a chronic cough, and then this progressive shortness of breath, which is related to the hypoxemia that is accompanied with activity intolerance. So, and again, there's no cure for a COPD, and it is progressive, so it gets worse and worse and worse. And so the amount of activity that the body is able to tolerate starts to diminish. And so it's very important that we can recognize what's going on so that we can begin pulmonary rehabilitation and prolong or retard the progression of the disease. So in the late stages of COPD, patients may lose weight and become malnourished because of the effort it takes to eat. As I talked to you before, is with the soft palates, when somebody goes to chew, they and the food is in the oral cavity, the soft palate is going to move up and block the nasal cavities. The epiglottis is going to cover the trachea, and so really no air, can't eat and breathe at the same time. So it does create a dyspnea if you're having to chew really dry food for a long period of time because you're not getting any air. And when you're trying to swallow and breathe at the same time, there's this huge risk for aspiration. So, eventually people will quit eating. People with COPD will quit eating because it's just too much work. It's exhausting thinking about everything flowing and the risk for aspiration, and they'll just quit eating. So some of the things that we want to look for when a person starts developing a respiratory diseases, we need to notice what the signs and symptoms of COPD are, because again, it's progressive. And when we start recognizing that our patient or a family member is exhibiting some of these signs and symptoms, then we want to get them in to begin their pulmonary rehabilitation. So some of the signs and symptoms that you're going to see is that there's a very limited airflow and a chronic cough. We've already talked about that. They will have progressive dyspnea with exertion. So they will have activity intolerance. There will be this chronic wheezing that is heard. And air trapping in the lungs causes the alveoli to stay hyperinflated, which is going to give the appearance of a barreled chest. And then you'll notice that they will slowly start losing weight because they're avoiding eating. So, what are some appropriate goals for the person with COPD? As first of all, reduce symptoms. You want to increase the activity tolerance and improve their health status, because there's going to be so many complications develop because of the complications that come with immobility. So when they don't have enough energy to get up and move, they're going to quit moving. And then the complications are going to occur. So when we say it's progressive, it's progressive. I always said in my lectures that if you don't use it, you lose it. And that holds so true with COPD, that, and it's a legitimate excuse if you're not using it. You're too tired, you don't have the energy to do that. But just recognize that your muscles are becoming deconditioned the more you don't force yourself to stay active. So pulmonary rehabilitation is just crucial to increase your activity tolerance. You do want to reduce the risk for exacerbations. You want to prevent respiratory infections. And we talked about the different vaccines that you could get. And we also talked about the importance of smoking cessation. There is treatment pharmacologically for persons that have respiratory infections. Antibiotics, we talked about these antibiotics, mucolytics, and antitussives. But you do have to be careful with the antitussives because of any narcotic ingredients which may be in the cough medication. Why? Because it reduces the respiratory drive. So let's talk about some interventions that you need to remember to do with a patient that has COPD. And we talked briefly about pulmonary rehabilitation because this pulmonary rehabilitation will cause a gradual increase to the patient's level of functioning and their activity levels. So we need to teach them how to do to conserve energy, such as pacing activities with rest periods in between. You don't have to do all the morning cares all at once or before breakfast. You can space them out during the day if the patient needs it to be done. You also want to avoid working with their arms raised above the head, and we've talked about that because those same muscles that are used to expand the chest are also there to stabilize the shoulders and the arms. We also want to save energy by leaning their elbows on a table to do hand work, or by sitting so that they can conserve energy whenever they're doing housework or that type of thing. They can sit in a chair and still sweep the floor. Again, what is our goal with any elderly person is to maintain their highest level of functioning and independence. We can teach them to use adaptive tools for housework. And we don't want them to talk during times of physical activity because, again, you need to have air to speak. But if you're doing physical activity, it's utilizing a bunch of air as well to take in enough oxygen for the body to be active. So it's all interrelated. Yeah, it is. Okay, we talked during our lecture 2 about breathing techniques, especially during times of anxiety or panic. And so we talked about diaphragmatic breathing and we talked about pursed-lipped breathing. We did use the word abdominal breathing, synonymous with diaphragmatic breathing. So just be aware of that. And we taught how to do diaphragmatic breathing, and we talked about how doing pursed-lipped breathing. Also, positioning is a huge intervention that we need to consider when we're helping and assisting a patient with COPD. We talked about postural drainage, and you may have to go back to your fundamental books to review that, but you always do the postural drainage positioning after their chest has been percussed or there's been a vibrator that has been used on the chest and the back to break up the secretions in the lungs. We also want to gradually increase exercise as tolerated. And we want to teach them to increase or recondition their accessory muscles by having them breathe against resistance, because that will help with their accessory muscles. We also want to have the patient sit up in the chair for 1 hour, at least 2 to 3 times a day, because this again allows full expansion of the alveoli. So there's some other things that we didn't talk about during the lectures, and I just wanted to be sure to mention them. First of all, teach your patients controlled coughing to clear secretions at specific times of the day. So what is controlled coughing? So to cough effectively, you want to teach the person to sit in a chair with feet firmly on the floor. So they're sitting forward just a little bit. I don't know. It just kind of inspired me to sit up a little bit instead of laying back down. I swear to you, if it was my call, I'd be laying in bed talking to you, but I can't do that here. So anyway, have them sit up in the chair with their feet firmly on the floor, and then instruct the patient to turn their shoulders inward and to bend their head slightly forward like this. And then they can use a pillow up against the chest if they need to have a little bit of support. Then you want to have the patient take a few deep breaths while they're holding their pillow. And then after the deep breaths, you're going to have them bend forward slightly, and then you're going to have them cough 2 or 3 times with the same breath. Don't have them breathe in between. Don't have them fill their lungs again. Just breathe the same breath. And then they can return to their original position and take a couple of more deep breaths so that you kind of stabilize, because it takes a lot of energy to control your cough. So again, let me repeat that to you because I didn't mention it in the lecture, and I thought, I need to mention that. Why? I don't know. Why? But anyway, what you do is have the person sit up, feet on the floor, shoulders slightly bent, head a little bit forward, holding on to a pillow. Take a few breaths. And then I don't have any productive sputum, sorry. But anyway, have them take a few coughs within the same breath, and then relax, sit back a little bit, sit up a little bit, breathe deeply for a couple of times before you repeat the procedure. That is called controlled coughing, and allows you to use muscles that will get to the deepest part of the lungs. Okay, so you want to cough when you get up first thing in the morning to clear the secretions that have accumulated at night, and we all know that they've accumulated at night. Why? Because the cilia is paralyzed. It's not working anymore. Why? Because the person has smoked. All right. So you want to cough to clear mucus before meals, so that, again, you'll have greater surface area for gas exchange, so that hopefully that will provide oxygen, that you won't get so tired while you're eating. You want to cough, instruct your patients to cough before bedtime because it will help with sleep. And then if there are times when a person has severe shortness of breath, then they need to have a written plan as what to do so that they will learn to do that. At the first, they may just resort to a little bit of panic, but what we're trying to do is get them to do diaphragmatic or pursed lip breathing, slow down, control their anxiety. We want to talk to them about disease progression and let them know that they will probably need to utilize oxygen as the disease progresses. We also want to suggest using a bronchodilator maybe 30 minutes before a meal that will help dilate the bronchial tree to provide enough air intake to be utilized. Again, we talked about wanting the person to maintain as much independence as possible, but with people with COPD, eventually you are going to have to assist them with their ADLs whenever necessary. Another thing that you want to instruct them to do is to maintain adequate hydration so that the secretions will be thinned so that they'll be easier to cough up and expel. So recommend 2 to 3 liters of water per day. At night, recommend using humidifiers. You can also have them include family and friends in any support groups that they visit so that all in the family will be educated on the disease. And always, we want them to teach the patients to pace their activities and so that they're not doing everything at once. We did talk about supplemental oxygen. You know, when they have supplemental oxygen, have you ever gone into a patient's room that's on supplemental oxygen in the hospital and like the nasal cannula is laying right there in the bed? Yeah, it sucks because it's like, okay, where's the patient? They've gone to the bathroom and it's just easier to have the oxygen off. So when you have a person that has COPD and needs and is still able to ambulate to the bathroom, you need to make sure that you notify respiratory therapy to come in and bring one of those extension tubings for the oxygen tubing. And they can have those extension tubings 20 feet long. They can have them being 60 feet long. They can be 100 feet long. I took care of a trach-dependent kid in home health once, and her oxygen, she was ventilator dependent. Her tubing went down from her bedroom upstairs, down the stairs, through the living room and into the dining room so that she could eat. It was that long. Yeah. And so you need, as a nurse, to ensure that there is enough tubing there so that they can utilize their supplemental oxygen to walk to the bathroom. And why is that? Because you're expending energy and oxygen when you're ambulating. So this is a time that for people with COPD that already have dyspnea or a diminished surface area for gas exchange, this is the time they need their oxygen. Yeah, they do. So just be aware of that. And also have suction available, because if the patient is too weak to effectively cough and they have adventitious breath sounds, then you want to assist them with suctioning. Okay, the last thing that we're going to talk about are some of the complications that are used for COPD. We've already talked about respiratory infections. We've talked about respiratory insufficiency. We've talked about cor pulmonale. We've talked about impaired gas exchange. And really, remember, the best way, the most important intervention that you can do for improved gas exchange is to clear the airway, because we've got to have an open, clear airway so that gas exchange can take place. That's the whole reason why we intubate a patient, is to maintain a patent airway. And so if a person has mucus in there, get the mucus out so you have a full lumen to intake air and to expel it. We've talked about some length about anorexia, that the person is just too tired, it's too exhausting to eat, so they eventually quit eating. So just be aware of this little tidbit, which I didn't mention in the lecture, but it's important for you to know that calories that are produced from fat are less when fat is metabolized, Utilize less carbon dioxide. Oh, that didn't make sense at all. Let me rephrase that, okay? That the calories that are received from eating a diet high in fat have less carbon dioxide metabolites than carbon dioxide that is produced from carbohydrates. So you don't want that. You want oxygen in the blood. So what we need to do is have a high fat, low carb diet for people that have COPD. That makes sense? You want me to say it again? You want me to read it? I'll read it. Okay, so because the calories from fat produce less carbon dioxide when metabolized than carbon dioxide produced from carbohydrates, then the diet with increased fat and decreased carbohydrate may help a person with COPD. There you go. Little bits of knowledge here. All right. We also want to monitor a weekly weight. Again, I think we've already mentioned that giving the patient a bronchodilator or a little puff on their inhaler 20 minutes or 30 minutes before meals can definitely help. We want them to avoid dry food and caffeinated beverages, avoid drinking fluids and during meals. Why? Before and during meals. Why? Why are we doing this? Well, think about what we're trying to achieve here. We're talking about a person with anorexia, so they have weight loss, they have the decreased nutrients that they're taking into the body, which is not going to help things at all. So if you drink a lot of fluid that have no calories or no nutritional merit to them, or you're drinking fluid during meals, then your stomach's filling up with no calories, or calorie-free or minimal calories instead of taking in nutritious food. So we want to avoid drinking fluids before and during meals. And then providing liquid supplements. I think we talked about that during the lecture. So what are some things that we can do for a person that has activity intolerance, which can be a complication of COPD? I think we've mentioned several times that we need to space activities between periods of rest to prevent the person from getting worn out. We want to assist with ADLs when necessary, and we want to plan sex. Yes, we do. Kind of takes the fun out of it, I think, if I remember correctly. Yeah. So anyway, when should you plan sex? Well, after a nap. Or it could be before a nap. Or you may need a nap afterwards. I don't know. Just plan your sex, okay? Another complication that you're going to have is an ineffective breathing pattern. Don't forget, we talked in this review specifically about the different kinds of breathing patterns there are. And I'm just saying, study what you want, but you're going to need to know those. But ineffective breathing pattern is not going to be sustained or tolerated for a long period of time. So research has indicated that patients with a breathing pattern of greater than 27 breaths per minute has a very poor prognosis. And really, when you think about it, 27 breaths per minute is not that much more than 20 breaths per minute. So again, ineffective breathing patterns will definitely affect the person's respiratory insufficiency. And then we talked briefly about anxiety, and you need to be very careful with any kind of narcotics that are given. Morphine, if there's morphine given for pain or discomfort, or you have any kind of anti-anxiety medicine that may have some narcotics in it, you have to be very, very careful because of those things. Those medications depress the respiratory drive. Well, and there you have it, people. 50 minutes of sheer joy just given to you to review for the test. I know I go fast during these reviews, but basically, as I've said on numerous occasions, these reviews should be done after you've studied. So this should be basically a review for you. It shouldn't be new information. There was a couple of new things I threw in there that I hadn't mentioned in the lecture, but overall, it should be just a review for you of the information to help you study or to just affirm what you have studied or clarified what you have studied in preparation for the exam. On Monday, you're going to be all Chantel's. Yes, you are. After the exam on Monday, Chantel's going to begin the infamous cardiac lectures that goes on for a couple of class periods. And then I come in when it's all over and do adult cardiac. So just be aware of that. So I'll miss you guys. And what I'll miss the most is that you're supposed to be coming back to class face to face next Monday. But Jody's going to put out a email about it. So wait for the email to tell you exactly where to go and when to be there. So just be aware of that. But it'll be a couple of weeks before I see you again. But I'll be thinking of you the whole time. All right, squirrels, I'll talk to you later. Happy studying. You know, I'm always there by text. I do go to clinicals this week with the PN1s for the very first time. So pray for them. All right, we'll talk to you later. Love you. Bye.